Welcome back to OncoHub. In this video, we present a complex case of retroperitoneal lymph node dissection combined with left nephrectomy for a residual left paraaortic mass. 17-year-old boy was diagnosed with right testicular non-seminomatous germ cell tumor, in this case a York sac tumor with stage 3 disease. He underwent 3 cycles of neoadjuvant chemotherapy with BEP regime, following which the tumor markers had normalized with residual left paraaortic mass. So the plan was to go ahead with the left paraaortic mass excision plus minus left nephrectomy with complete template RPLND. The CCT revealed a 8 into 8 cm residual tumor of left paraaortic area sitting over the left renal hilum. Here vertical midline incision has been made, and on entering abdomen, left colon has been mobilized and left ureter has been looped. The omentum adhered to the tumor here is being detached. Also, the gastric colic omentum has been separated. Now we're moving to the separation of the large bowel mesentery, which is adherent to the tumor underneath. Gradually moving proximally from distal end on the lateral aspect. Now that's the splenic flexure and the descending colon and the paraaortic mass underneath with the adhered mesentery, of course. Now the mesentery is being separated, taking care to leave the marginal vessels intact. Any discoloration of the splenic flexure should be resected and end-to-end anastomosis should be performed. That's the last attachment of the mesentery being separated from the tumor. Now we are working at the paraaortic area. We are going from caudal to cranial direction, creating some space between the aorta and the tumor. Now that's the pancreas above. Yes, the pancreas above and the paraaortic mass below. So we'll have to separate it from the pancreas. That's what we are doing here. Gradually, bit by bit, we are coagulating and cutting with a bipolar sealing device, in this case a ligashure. Slowly we are moving along the entire length of the body and tail of the pancreas. Now we are removing a hilar lymph node, which will allow us to visualize the hilar vessels, the renal vein and the renal artery to take control before proceeding with the rest of the dissection. That's the renal vein, which is being looped here with the vessel loop, and just underneath it, as you can see, is the renal artery. Now we have taken control of the renal vasculature, both the renal artery and the renal vein, is in our control. Now we gradually again proceed with our paraaortic area dissection, separating the aorta and creating a space between the aorta and the tumor. In this region, usually the lumbar vessels will be encountered, and they are usually small and can be taken care with the ligature. Now the loop is the ureter. You can see the ureter clearly going through the tumor. That is, it is encased by the tumor. So we have made a decision to go ahead with the left nephrectomy en bloc with the removal of the tumor. That is the gonadal vessels being tied and ligated off. Now that is the ureter being tied and clipped and will be subsequently cut. Now that is the suprarenal vein which is being coagulated at two places and will be cut. Now the suprarenal gland is being separated here from the upper pole of the left kidney, and hence suprarenal gland will be preserved in this case, as there is no involvement of the gland. Now the renal artery will be tied first, as is usually the case in all nephrectomies. The artery first approach should be followed. We are also putting a hemlock for extra security. The renal artery being cut here. Now the last structure to be ligated is the left renal vein. The hemlock clips being applied and cut in between the ligatures. Now the posterior dissection and the attachment with the spleen is not shown in this video. So the entire specimen is now free of any attachment and is being removed. Now we are moving ahead with the rest of the RPLND template dissection. Now the residual remnant left paraaortic lymph nodes is being removed here at the hilar region. Now we are working on top of the aorta. We are basically doing a split and roll technique. Firstly, we are splitting the lymph nodes in the center of the aorta here, coagulating with the bipolar, and we will be cutting here with the scissor. We're moving from caudal to cranial entire length. from the bifurcation of the aorta to the renal vessels. Above, there's a pre-aortic lymph node packet being removed. Now we are doing the split and roll over the IVC, which has been completed here. Now we are rolling the vessel laterally, and we are doing the intra-aortocaval dissection. We are starting at the superior aspect, just underneath the renal vessels. We always clip before we remove the lymph node. This helps prevent any chyle leak post-operatively or chylous ascites. As you can see, we're moving in the caudal direction. The lumbar vein or artery being encountered is being taken care of. We're separating it from the IMA on the left side. That's the entire lymph node, interaortocaval lymph node packet. Now we are ligating the inferior most part of that packet before removing it. Now we have switched on to the right side. This was a right-sided testicular tumor, so it's advisable to tie the right gonadal vessel and to remove it along with the paracaval group of lymph nodes up to the deep ring. As the gonadal vessel entirely being separated. That's the picture at the end of the dissection. Thank you for watching.